This topic may seem strange, but in fact, it is at the frontier of the two previous presentations, I think. The more I was hearing at those two presentations, the more I think it was important to speak about the importance of bone implant interface and sagittal balance. And I shall try to convince this for you. So when we speak about this replacement, we mainly speak about functional performance. It means range of motion, flexion extension, translation. People don't speak a lot about translation, about share, and the mean center of rotation. And also, we had the opportunity in previous webinar to speak about center of rotation, and we are convinced it is something very important, but it is a functional performance. But in this replacement, there is another concept, which is the adaptation regarding the vertebral end plates, and it was one of the previous questions, and the influence of the sagittal balance. And most of time, we look at limited X-ray, like this in this example, with flexion extension X-ray. So we are very happy to have good range of motion. We don't analyze very frequently mean center of rotation, and we have few experience about the study of the adaptation of end plate regarding implants. Perhaps you know I am an anatomist, and on the left it is my surgical vision of a cervical disc. We have only an AP view during the surgery, and we are very happy to have good X-ray, perioperative X-ray, no problem. But look on the right, some of my sample, you see the shape of the end plate are very different. We see those end plate from anterior. We don't see them very well as a surface. And we have very different situation regarding the bone density, the cyst in the end plate before surgery. I shall speak about this. And you see the density as in the middle case, you see with a lot of density in some patient. How to deal this surface, because we need to have bone ingrowth in our implant. It is the same thing at the lumbar level. On the left, I am very happy about this disc implantation. I am very happy to have good perioperative X-ray. But the situation are very different. Look at those different discs which were probably black disc. You see the end plate are very different. So perhaps we must open our mind regarding this. When we speak about end plate, we must remember the microanatomy. We have the nucleus, we know vertebral end plate, but inside of this vertebral end plate, you have subchondral bone, sometimes very dense, and as we need to have bone ingrowth and good bone adaptation, we must break this dense subchondral bone without weakening the end plate, of course. And you see there are marrow cavities. Probably you will look in a different way after this, the preoperative CT scan. If you look in a very precise way, you will see that you have small cysts due to liquid inside of the end plate and due to the vascular properties of the end plate. And of course, we should have different adaptation of the end plate. Mechanical or viscoelastic prostheses are implants. And as hip and knee prosthesis, we have adaptation of the bone stock. Look at those two cases. One case on the left, apparently a silent evolution of the end plate, and on the right, a more dense and reaction of the end plate and a more heterogeneous evolution of the end plate. And the question is, what was the situation before the surgery? So for the preparation of the end plate, it is very important to have a good preparation of the end plate to obtain good bone fusion. But it is not very precise. I want to share some detail with you. It is also important to avoid hypermobility, but what kind of hypermobility? And of course, to have the culture of the radiological follow-up of the bone implant interface. We must convert ourselves in a way to hip and knee surgeon, because hip and knee surgeon have the culture of the follow-up of the patient regarding bone reaction. Look at those patients with long-term follow-up. I did viscoelastic implant like Marc-Antoine since about 15 years, and you see the end plate are not the same. L5S1 end plate very often is relatively silent, and sometimes may have some radiolucent line, as you can see, for example, in the case 2. Is it dangerous? Is it a problem? We have to speak about this. Look at those X-ray. Most of time now, we look at RMI, but we miss very important thing. Look at the CT scan. It is the same patient, and you see you have a cyst in the end plate, and you have a bone reaction, very different bone reaction anterior and posterior to this disease. How to deal with this? For example, to obtain a good bone fixation, we need to break with the density of the end plate to make the implant communicate with the bone marrow. Personally, I use small pin to do small hole in the end plate, as I do for a cementless cup, for example, when the bone is very stiff and very dense. Of course, we must not create a weakening of the end plate, but doing small holes is, for me, a good solution. So when we put an implant, we need to have at first bone integration, so a good direct contact between the bone soft tissue and the implant without interposition of fibrosis. I think you will see one of the very important message is when I put my implant against the bone, we imagine that the bone remains perfectly in contact with the implant. It's not true. It is very well published that you have immediately a small interpositioning membrane which will be transformed in bone after, but quickly, but not immediately. And then after, we have the step of bone remodeling introduced by changes in load distribution when the prosthesis is implanted into the bone tissue. So two steps, bone integration and bone remodeling. So it's strange. I speak like a hip or a knee surgeon, but it is very important because within the first 2 months, we need to have primary stability. As for a hip, and micro movement have been very well precise for hip. You have here in red the limit for micro movement. So you can say it's very difficult to have a good measurement of those micro movements. Okay, but we must be aware of this. Look at this case, for example, if it is a case of mine, 1 month post-op, you see radiolucent line. I probably did not a perfect preparation of the end plate. 6 months, I was a little bit anxious. I asked the patient to wear a small soft brace to limit the mobility. And after 5 years, it was perfectly integrated. So if you have a radiolucent line at the beginning, you must be careful. I am careful, and it is not a failure of the procedure. We must wait because it is biology. And after 1 and 2 years, of course, we have remodeling of bone due to mechanical factor. And of course, in those examples, you see, for example, the bottom case on the left, you had a small slipping of the prosthesis, and then it was locked and with good bone ingrowth, probably because the patient did not respect limitation of mobility and he had a delayed bone integration. So you can say to me, okay, it is theory, but there is a lot of theory about this and a lot of literature. For example, this paper from the HSS journal, the conclusion is mechanical stimulation of periprosthetic bone from fluid, pressure, and flow can induce osteolysis. What does it mean? It means that when you implant a prosthesis, immediately you have periprosthetic membrane. If you have too much mobility, but it is not a huge mobility, but you have progression of fluid between the implant and bone. And as you see on this prosthesis at the top, whatever the brand is, it is not a problem. And you have those small cavity between the end plate and the bone. Does it mean it is finished for this implant? No, because it is biology. And if you are careful, if you ask the patient to be careful regarding mobility, you may have a good final bone ingrowth. This other paper is also very interesting. It is a very well-known paper. Two conclusions: favorable initial condition or a race to surface where osteoblast win should be the goal. I think it is a very important message for us as spine surgeons. The race to the surface, the race to obtain a sufficient contact to have good bone stabilization. And only in the case of hydroxyapatite coated implant does the motion-induced fibrous membrane convert to bone over time. And we have several papers publishing this, and it is an old concept within 20 years for hip and knee surgeons. So the concept of race to surface. So if you look at those cases, for example, at 2 or 3 years, you see still a small radiolucent line, and all those cases after were followed, and we had good bone integration. And I can show you also those examples. You see, 5, 7 years, we publish those cases. You have bone integration. The interface after this is silent. At 7 or 10 years after, we shall see. But today, we can say this. So we have different situations. The good situation, the patient without any reaction of the end plate, and the patient with some density, some small cyst, perhaps because we did not prepare in the good way the end plate, or perhaps because we had a small accumulation of liquid. But is it a big problem? Look at those hip images. Sorry for showing this to you, but it is my common life as a cementless hip surgeon. And you see, there are modification of the bone behind the prosthesis, not because of wear, but because of adaptation. So what are the limitations for mobility? This paper is very interesting because it shows you when you do axial rotation and lateral bending, what are the critical levels. On the left, this paper shows that when you do maximum axial rotation, you may have at L5S1 and L4L5 more or less 4 to 5 degrees rotation in a normal spine. It means that if you don't ask the patient to be a little bit careful to do maximum rotation, you may have normal or delirious rotational movement, which can be a problem for bone integration. It is not for a long time, but it is, as I spoke to you, for the first 4 weeks or 6 weeks. Now, if I do bending, it is interesting also. L4, L5, and L5S1, also you have axial, you have bending angulation. You see 2 degrees. Probably between bending and axial rotation, the most delirious movement to make the patient aware of is axial rotation. I say this to my patients since years. So it is a summary of this very interesting paper you can find. You have a kind of functional scoliosis when you do rotation. Interesting concept. And what about cervical disc? What are the limitations? This paper is also very interesting. In black, flexion, extension, range of motion. In red, lateral bending. And in blue, axial rotation. Very quickly, you see here, when you do flexion extension in black, so you have maximum flexion extension, the most risky level are C4, C5, C5, C6, about 4 degrees for lateral bending and axial rotation. So you can say to me, but it is okay, it is not a lot, but for small bones bridges, it may be a problem. Now we do lateral bending, and you see that 3 levels are more risky, about 6 degrees for rotation. So when I accept that the patient does a lot of lateral bending, I do, despite the ancus, I do rotation, potential rotation at the level of the prosthesis. And now, if I accept the patient to do maximum axial rotation, look at this. You have also at the level of the disc, so at the level of the prosthesis, until 10 degrees bending. So what is the message? The message is not to ask the patient not to move a lot, but it is to be aware of this to avoid delayed bone ingrowth. Now to finish, what about global balance? What are the problems? Patients with high pelvic incidence because they have a lot of mobility in the sacral slope, so more risk of slipping. In the patient, when you have a lot of delordosis, so ask them not to sit too low. In patient with strange mobility at the hip, you see this patient does not sit using fully his hip. Patient with posterior translation of the upper part of the trunk. So patient with a high risk of hypersolicitation for translation. And also patient with pelvic rotation. Look at this patient with a large iliac wing here, a narrow iliac wing here, so you have rotation in the pelvis. Cervical spine to finish, and it was one of the questions to Marc-Antoine. The patient with a low T1 angle, so this type of stiff and kyphotic spine, we must be aware of this. And those patients with hyperlordosis with high level of T1 angulation of the hand plate. So the take-home message, we must be a little bit like hip and knee surgeon. Disc implants require us to think about the intrinsic functional capacity, we know, but also their interaction with the recipient bone side. It does not mean limitation of mobility, but we must be aware of small details making our life much better after. Thank you.